Dr. Nirma, third year radiology resident from Nizam's Institute of Medical Sciences. I will be presenting the topic of CT coronary angiogram. So this is the overview of the CT coronary angiogram. I will explain this further. So starting with the CT angiogram, it is an anatomical imaging modality that allows for visualization of the coronary artery lumen and wall using an IV contrast agent. It is now considered a first-line test for use in acute and chronic coronary syndromes in symptomatic patients. And it increases the diagnostic accuracy in detecting the calcified plaque, arterial narrowing, acute plaque, arterial stenosis and arterial anomalies. So coming to the indications, in evaluation of the coronary artery anomalies, atherosclerotic coronary plaque and in occlusive disease, and to know the patency of the CABG, stent patency and evaluation of the coronary artery disease due to atherosclerosis, non-atherosclerotic causes and alternative to invasive coronary angiography when it is not feasible or it carries higher procedural risk. And the basic contraindications are divided into absolute and the relative. Coming to the absolute contraindications, acute STEMI, severe allergy to iodinated contrast, pregnancy, and the relative contraindications are inability to hold breath, irregular heart rhythm, low systolic blood pressure, moderate to severe aortic stenosis, renal failure, and very high coronary calcium score when it is greater than 1500 because they are severe blooming artifacts. And indications in native vessels and post CABG. In native vessels, it is first line test for evaluating patients with no known coronary artery disease who are present with stable, typical or atypical chest pain, or known coronary artery disease who present with stable, typical or atypical chest pain, and in a non-conclusive functional test or in revascularization strategies and selected asymptomatic high-risk individuals. In post-revascularization patients like with intracoronary stent diameter 3 mm or in prior CABG for graft patency or prior to redo cardiac surgery. Challenges in coronary CT-CAG were, these are very small in diameter like 2 to 5 mm and the distal one were reaching up to 1 mm. So we need the fine imaging, that's the spatial resolution of 1 mm. And we need fast imaging, temporal resolution, and the coronary contrast resolution too. It is very mandatory. Coming to the calcium score, we are using Agatston method to score the calcium score. Based on this, we can characterize the coronary plaque. And this is the acquisition protocol. The position is supine, axial with prospective ECG gating, and scan range from below aortic arch to the base of heart. And based on the MI, we can adjust the tube voltage. Section thickness is 2.5 mm with interval of 1 mm, and we are using Agatston method. There are like 3 plaques: soft plaque, mixed plaque and calcification plaque. That is 60 to 130 is the mixed plaque, less than 60 is soft plaque, and greater than 130 is calcified plaque. This is the overview that we can calculate the calcium score for individual arteries, LMCA, LED, LCX and the RCA. I will show the video further. So we can characterize the coronary plaque based on the coronary artery calcium score it into mild, moderate, severe, and it is extensive. If it is extensive, we can stop the CAG scan. According to the North American Society for the Cardiovascular Imaging, there are few standards, like equipment standards are CT systems with gantry rotation time equal or less than 350 milliseconds. And the minimum detector requirement is 64 slice scanner, and there are dual head injection pumps that allows biphasic or triphasic. There are 3 phases like monophasic, biphasic or triphasic. In monophasic we used only contrast. In biphasic we are using contrast and after that saline chaser. In triphasic there are like 3 steps. In first step we are using contrast, second is mixed one like contrast and saline, third is the only saline. It is advanced one, but we are using the standard one, that is biphasic. Coming to the patient screening, if before the CT coronary angiogram scan, we should screen the patient to rule out any contraindication like pregnancy or any other pertinent medical history, or to ability to follow breath hold commands. If pediatric patients are unable to cooperate, anesthesia will be required, and assessment of the heart rate, pulse and BP. Or contraindications to iodinated contrast agents, because if there is any renal insufficiency or metformin containing medications intake or prior allergic reactions, or contraindications to nitroglycerin, contraindication to beta blockers because of asthma or AV block, COPD, decompensated heart disease, these all are contraindications. So There are few pre-test instructions like no food for 3 to 4 hours prior to exam, may drink water or clear fluids until time of exam, no caffeine products for 12 hours prior to exam, take all regular medications the day of exam, especially blood pressure medicine, take pre-medication for contrast allergy if present. It is reasonable to suspend metformin for at least 48 hours. We should take informed consent. IV access 18 gauge catheter is often necessary in adults. In normal or small patient 20 gauge IV catheter required. For pediatric patient 22 gauge IV line. The right antecubital vein is preferred. For the post CABC patients every time we should take right side only. Breath hold training. Because coronary CT angiogram should be acquired during a mid-inspiratory breath hold. So minimum 10-second breath hold training should be adequate. To ensure appropriate quality of the breath hold, to ensure adequate timing of the breath hold, and to observe fluctuations in heart rate and rhythm during the breath hold exercise. Pre-procedure medications for desirable heart rate is less than 60 per minute. So if there is more than 60 or 65, we should give beta blockers like metoprolol, that is oral metoprolol, and IV esmolol. Oral metoprolol can be given up to 20 to 25 mg. Esmolol, that is the IV esmolol, which was very rapid action and it has short half-life. It can be given at 0.8 mg per kg. Ivabradine if beta blockers were contraindicated. And nitrates, that is the sublingual nitrate, 400 to 800 microgram of nitroglycerin on table 5 minutes prior to the coronary CT angio. So after a patient is on the table, the patient positioning is very important, that supine with arms raised above the head and the heart, centered within the gantry. This horizontal positioning laser light should lie at the junction of the anterior one-third and the middle one-third of the patient's thorax, both arms above the heart. ECG lead placement. The number and preferred location of leads depends on the scanner type and design. R wave peak should be twice than the T wave. So coming to the contrast injection protocols, that is biphasic. For stenosis detection, it should be 250 to 350 HU. Why? Because if it is less than 200 HU, there is poor 3D image of coronaries, and if it is greater than 500 HU, there is significant underestimation of stenosis in smaller vessels. That injection rate is 5 to 7 cc per second, and injection duration should be at least 10 seconds, and typical contrast volume is 50 to 120 cc. And we should keep the region of interest at the ascending aorta, and we need to delay the scan for 2 to 4 seconds because to allow complete filling of the coronaries. There are two methods like test bolus and the bolus striking. In the test bolus method, we are injecting test bolus 10 to 20 ml of the contrast, followed by the 30 to 50 ml saline flush, followed by the acquisition of a series of dynamic low dose images. But there is a disadvantage that 15 to 20 ml of extra contrast media, longer scan time. But here in the bolus tracking method, which we are following here, there is full dose of contrast is given at once, and the scan is triggered, which were manually or automatically, when the attenuation in the ROA exceeds a predefined threshold, that is 100 to 200 HU. But there is delay time 3 to 5 seconds after the trigger threshold, and the advantages is more simple, convenient, and faster with less contrast volume. Coming to the acquisition parameters, there are like field of view, which is 512 into 512, 200 into 250 mm, scan range, tube voltage, tube current, gantry rotation time, collimation, pitch. Coming to the scan range, native vessels, for the native vessels, it should be below the tracheal bifurcation, just below the lower cardiac border, which approximately 12 to 15 centimeter. For post-CABC patients, middle third of the clavicle till just below the lower cardiac border, approximately 18 to 25 centimeter. Because in CABC patient, there is like REMA to LAD grafts or LEMA to LAD grafts, so we need to take from the middle third of the clavicle. So the field of view is 512 into 512, 200 to 250 mm. Tube voltage is 120 kV tube. Tube current, there are like anatomy based tube current modulation, ECG based tube current modulation. Detector collimation is minimum is 64, and it is less than or equal to 0.625 mm. Pitch is 0.2 to 0.4, which is low pitch, because if selected pitch is too high for a given heart rate, there will be gaps in the data, which was resulting in volume gap artifact between image tag with missing cardiac anatomy. There are like 3 types of data acquisition: prospective, retrospective. In prospective ECG triggered, there is high pitch, helical or spiral acquisition. So we should take the scan in with at least cardiac motion, that is the 70 to 80% of the RR interval, where there is least cardiac motion. If heart rate is less than 70 beat per minute in mid diastole, if heart rate is greater than 70 beat per minute, that is in early systole. So there are 3 types like prospective, retrospective, and the prospective helical pitch. In prospective ECG trigger, X-ray tube is activated only during a pre-specified phase of the cardiac cycle, that is in least cardiac motion. That is in 70 to 80% of the RR interval. But is in Retrospective, here X-ray data are acquired throughout the entire cardiac cycle. So the disadvantage is high radiation, but we are considering this in cases where heart rhythm is abnormal or rate is high. So in prospective, here there is delay, X-ray was on, again moving couch stop, preset delay, X-ray is on. Only we are taking the data where there is at least cardiac motion. But in retrospective, we are taking in entire length, but the temporal resolution is 80 to 250 milliseconds. Radiation dose is higher than the prospective triggering. This is the ECG gated tube modulation, that is in retrospective where we are taking data in entire length. When we use this ECG gated tube modulation, we can deliver the less dose in rest of the phases. Only we are giving more dose at the point where in mid diastole. Reconstruction method is very important. In the past we are using filtered back projection, but in recent times there is most hardware systems allow for iterative image reconstruction. So there are two types like partial half scan reconstruction and multiple segment reconstruction. In partial scanning algorithm we are using only single heartbeat, where here we are using successive heartbeats. Here we are taking continuous segment of the projection data, but here we are using different segments of projection data from the same phase of the cardiac cycle but at successive heartbeats. Coming to the reconstruction kernel, there are three types of reconstruction kernel like semi-sharp and soft or smooth kernel. In soft or smooth kernel, we are using to reduce the image noise in obese patients, whereas in semi-sharp we can use in most of the patients, whereas in sharp kernel we use it to reduce the blooming and increase edge definition, that is in metallic stent artifacts or where there is more amount of calcium which gives more blooming artifacts. These are the processing techniques like multiplanar reformation, maximum intensity projection and 3D or 4D volume rendering. So this is the MPR reconstruction in coronal, axial and the sagittal or oblique planes, which allows for the visualization along the vessel course. This is the curved planar reconstruction which displays entire coronary artery in a single plane along its central line, which allows for seeing continuous vessel assessment and the long segment stenosis. This is the maximum intensity projection which can be used for detecting stenosis or visualizing calcification. We can visualize the calcification in the RCA, in the LCX. This is the volume rendering technique which can be helpful in 3D anatomical visualization. So this is the basic one to distinguish native coronary and coronary bypass grafts. The method was different for these three, like coverage area, scan length, heart rate requirement, spatial resolution, temporal resolution, artifacts, ECG gating, reconstruction, post-processing and radiation dose. So this is the basic native coronary vessels CT CAG. This is the RCA, this is the LMCA and this is the LAD. This is CT CAG for the stent. We need to know the stent patency. This is the CABG CT CAG. There are like RIMA to LAD, LIMA to LAD and SVG to OM and SVG to PDA. So we can visualize there is no contrast in this graft. That is a non-opacification of the graft here and here, but here we can visualize the contrast opacification. So this LIMA to LAD graft is patent, and but here in SVG to RCA graft there is wall calcification and there is total thrombotic occlusion. There is no contrast within the graft, that is the occlusion of the graft. So in our institute we are using Siemens. First, before the scan we should check the heart rate, we should check the pulse rate. It should be below the 60 per minute. And we should enter the details after that cardiac mode, taking the topogram, adjusting the field of the view. This is the pre-monitoring phase where location is below the level of the carina at the ascending aorta. And this is angio planning. Here we can place the ROA in the ascending aorta. So after coronary artery calcium score, we should plan the scan, placing ROA in the ascending aorta, injecting contrast and the saline, that is the biphasic, and monitor HU, trigger at approximately 120 HU, like 100 to 150 HU, preferably at approximately 120 HU. Manually or the automatically. We need a short delay like 2 to 4 seconds for the complete opacification of the coronaries. Start ECG gated CCTA. So this coronary angiogram scan range is above the coronary ostia, that is the carinal level, to the cardiac apex, and use these images to plan accurate coverage and avoid unnecessary radiation. And here the region of interest is in ascending aorta. This ensures proper timing of the contrast arrival to coronaries. And contrast injection, like inject iodinated contrast, typically 60 to 100 ml at 5 to 6 ml per second. After there is saline chaser 30 to 50 ml. Why this saline chaser? Because to reduce the streak artifacts and to improve the contrast utilization. And to initiate bolus tracking, begin low dose monitoring scan, set a trigger threshold, that is 100 to 150 HU. We can use it in manual or automatical way. triggering the scan, and ECG gated acquisition. Prospective or retrospective? Prospective has lower radiation dose compared to the retrospective. Breath hold instruction is very important, because if there is no breath hold in the scan, we can get more motion artifacts. And image reconstruction, reconstruct image in the mid diastolic phase where there is least cardiac motion, that is in 70 to 80% of the RR interval phase. So this is how to check the calcium score. So this is the LMCA, LAD, and this is the RCA. We should place the marker on the RCA, LMCA, LAD and the LCX, and finally we are getting total coronary artery calcium score here. This is a volume rendering image showing this is the LMCA, this is the LAD, this is the ramus intermedius, this is the LAD which we reaching up to the apex of the heart, that is the type 3 LAD, and this is the LCX. This is ramus intermedius, that is the trifurcation of the LMCA, and this is the right coronary artery, and it is giving PDA. This one which was showing the RCA arising from the right coronary cusp, and it is going in between the atrioventricular groove, and after that it is giving acute marginal branches. Finally it is giving PDA, and this is the curved planar reconstruction image showing the entire RCA. There is no stenosis, no calcified plaque, completely normal RCA. This is LAD. So LAD, this is the LMCA which was giving LAD. It is reaching up to the apex of the heart. There are three types of LAD. This is type 3 LAD which was reaching up to the apex of the heart, which was anastomosing with the PDA. This is the curved planar reformated image showing the entire coronary artery, that is LAD. Here there is myocardial bridging of the LAD, superficial myocardial bridging, but the entire length of LAD is patent. There is no stenosis and there is no calcified plaque. Third one is left circumflex artery which was arising from the LMCA. This is the LCX giving the obtuse marginal branches. This is a curved planar reformated image showing the same. So coming to the artifacts, there are like motion artifacts, blurring, ghosting, stage step artifacts, cardiac motion artifacts, respiratory motion artifacts, where we can see the discontinuity of the sternum and discontinuity throughout the heart, and there is a left ventricular myocardium too, there is blurring. Beam hardening artifact, metal or streak artifact in presence of the stent, slab or banding artifact, quantum mortal noise, calcium blooming. So if there is more calcium, we can correct it by improving spatial resolution, using sharp kernel, increased tube potential, increased display window. So basically we need to know the coronary artery anatomy. So this is the aortic root. This coronary artery arises from the sinuses of the valsalva. This is the right coronary cusp, this is the left coronary cusp, and this is the non-coronary cusp. From the right coronary cusp there is arising the right coronary artery, and from left coronary cusp, left main coronary artery, and from left main coronary artery there is bifurcating or trifurcating. In most of the cases bifurcating into LED and the LCX. In 20 to 30% of the cases there is trifurcation, that is the ramus intermedius. So this is the example where we can see the ramus intermedius between the LAD and the LCX. So LAD are three types like type 1, type 2, type 3. Type 1 is a short vessel. LAD terminates before reaching the apex. LAD supplies center apex and it is wrapping around the LAD. And it is divided into three portions like proximal, mid and distal LAD. Branches like septal, perforatus and the diagonal branches. Coming to the left circumflex coronary artery, it gives obtuse marginal branches which supply the inferolateral aspect of the left ventricle. Ramus intermedius, when LMCA will trifurcate into LAD, LCX and the ramus intermedius, which is in between the LCX and the LAD. Right coronary artery arising from the right coronary cusp and giving the acute marginal branches along the right border of the heart toward the apex. Branches are conus, sinoatrial, acute marginal, AV branch, posterior descending artery, posterolateral artery. So posterior descending artery is a mirror image of the LAD. Coming to the dominant circulation, there are three: right dominant circulation, left dominant circulation, co-dominant circulation. In right dominant circulation, PDA arising from the RCA. In left dominant circulation, PDA arising from the LCX. In co-dominant circulation, PDA arising from the RCA and the PLVB branch arising from the left circumflex artery. Few of the coronary artery anomalies, like in origin, course, termination, morphology. Coming to the anomalies of the origin: high takeoff, multiple ostia, single coronary artery. Anomalies of course is a myocardial bridging, which I showed prior to this. Duplication of arteries. Anomalies of termination are coronary artery fistula, coronary arcade, extra cardiac malformation. Coming to the recent advances, there are like a dual energy CT with calcium suppression and ultra high resolution CT. and phase contrast CT. So this is CT-CAG versus conventional angio, where risk factor is low. Here there is intermediate risk. Radiation dose is low in CT-CAG, where radiation dose is high in conventional angio. That is invasive procedure. This is non-invasive and low cost in CT-CAG. Conventional angio has high cost. Time duration is 1 hour. This is a daycare procedure greater than 12 hours. This is the overview which I showed in first slide. First is patient preparation. Heart rate should be below less than 60 beat per minute. Beta blocker if greater than 60. Sublingual nitrate if not contraindicated. IV line preferably is 18 to 20 gauge. Breath hold training was required. Workflow is first scout, after that calcium scoring, bolus tracking, after the acquisition. Reconstruction is very important to see the stenosis, calcium plaques, and to see the entire length of the coronary artery. Calcium scoring done in non-contrast scan. Carinative diaphragm helps in planning scan range. Coming to the bolus tracking steps, ROA should be in the ascending aorta, and contrast is 60 to 100 ml at the rate of 5 to 6 ml per second. Saline flush is important, 30 to 50 ml. That is the biphasic study which was standard one. Monitoring scans trigger at approximately 120 HU. Delay should be 3 to 8 seconds for the opacification of the coronary arteries, and we are starting the ECG gated scan. ECG gating is two types, like prospective and the retrospective. Prospective low dose, but retrospective has high dose, but we can use it in irregular heart rate. Breath hold is required. Gentle breath hold, avoid deep inspiration. Reconstruction should be in 70 to 80% RR interval where there is a least cardiac motion. Multiple phases if needed. Common mistakes are wrong RV placement. We should place in the ascending aorta only, poor IV access, no saline flush. Because if we use a saline flush, there are no streak artifacts. So there will be reduced streak artifacts if we use a saline flush. And mistakes like high heart rate, so there is a lot of motion if there is high heart rate, and improper breath hold technique. These are the common mistakes facing. Artifacts like motion artifact, streak artifact, step artifact. Motion artifact, we can, if we control the heart rate, we can reduce this motion artifact. If we use a saline flush, we can reduce the streak artifacts. If we use ECG gating, we can reduce the step artifact too. Thank you.